Ladies and gentlemen, thank you for standing by. Welcome to the Essentials for Childhood, Adverse Childhood Experiences and Implications for Prevention and Planning webinar. During the presentation, all participants will be in a listen-only mode. Afterwards, we will conduct a question-and-answer session. If you would like to ask a question during the presentation, please use the chat feature located in the lower left corner of your screen. If you need to reach an operator at any time, please press *0. As a reminder, this conference is being recorded Friday, June 20th, 2014. I would now like to turn the conference over to Ms. Lynn Chaikin. Please go ahead.
Good morning, everyone. My name is Lynn Chaikin. I'm the Director of Injury Prevention and Behavioral Health at the Association of State and Territorial Health Officials. I would like to welcome you to today's webinar, Essentials for Childhood, Adverse Childhood Experiences and Implications for Prevention and Planning. ASTHO, with support from the National Center of Injury Prevention and Control, is hosting this second in a series of 5 webinars that will feature Essentials for Childhood. The objectives for today's webinar are to cover these 2 main areas. We want to provide an overview of how knowledge of adverse childhood experiences, or ACEs as you hear it referred to throughout today, how ACEs support the importance of safe, stable, nurturing relationships and environments. And we also want to provide you with examples of how state health departments and their partners are using ACEs to inform primary prevention strategies in child maltreatment prevention. So we're really excited to have everyone here today. We have a wonderful panel. So after my initial instructions, each speaker will present. And if you have a question, we're going to have a brief Q&A following each presentation. You're welcome to post your questions in the chat box on your screen at any time. Please indicate to whom you would like to direct your question. And we'll also have a Q&A following all of the presentations to allow you to address the whole panel. Once our program ends today, you will be directed to an evaluation survey, and please take a few minutes to provide us with feedback on today's program. And please be assured that a recording of this webinar and all presentations will be shared with today's participants. Our first speaker today is Dr. Melissa Merrick. Dr. Merrick is a behavioral scientist with the Surveillance Branch in the Division of Violence Prevention at the National Center for Injury Prevention and Control. Her major research interests focus on the etiology, course, and prevention of child maltreatment. In particular, much of her current work examines safe, stable, nurturing relationships and environments as they relate to child maltreatment prevention. Dr. Merrick serves as the lead scientist for the Adverse Childhood Experiences Study and as a subject matter expert for child maltreatment. So we will advance to her presentation, and I will turn it over to Melissa Merrick.
Thank you, Lynn. Good morning. I'm really happy to be here today with all of you. I see there's over 270 people live on this webinar. So we're just really thankful for so much interest in Essentials and around adverse childhood experiences, or ACEs. So in the next 20 minutes or so, I just plan on providing an overview of sort of the state of the art of ACEs research, and specifically with a focus on how we can use these data for prevention action. So when people first think of child maltreatment, they likely picture images such as these, pictures of bruises, broken bones, maybe some mental health concerns like depression and PTSD, or post-traumatic stress disorder. But less likely, maybe they picture images such as these, chronic adult illnesses such as heart disease, asthma, diabetes, or stroke. But child maltreatment and other adverse childhood experiences can literally make us sick, impacting mental and physical health, brain development, and intellectual development across the lifespan. And the relationship between poor adult health and early adversity like child maltreatment has been repeatedly established. And much of what we know about this connection between early adversity and health outcomes comes from the Adverse Childhood Experiences, or ACE study, and ACE-related studies. So just a quick overview of the original CDC Kaiser Permanente ACE study. It started as really a collaboration between Kaiser Permanente, a large HMO out of Southern California, and the Centers for Disease Control and Prevention in the late 90s. And it was really a retrospective study of adult participants in this HMO with an average age of 57 years that were asked to recall experiences that may or may not have happened before they were the age of 18. And there were over 17,000 participants in this original ACE study. Here you can see some of the limitations of the sample, of course, that we're talking about an insured sample. We're talking about mostly white, mostly higher SES adults in San Diego. And again, you see the average age of 57, so they're having to recall, decades earlier experiences. At the bottom there, I just call you to our new website. This original partnership between CDC and Kaiser started in the Center for Chronic Disease and now has moved over to the Injury Center, in particular to the Division of Violence Prevention. And with that comes a keen focus on the prevention of adverse childhood experiences. Here you can see the various categories of ACEs that were assessed. Experiences of abuse, so acts of commission, emotional, physical, and sexual abuse, acts of omission or neglect, emotional and physical neglect, and then other indicators of family challenges that might have been going on under the age of 18. So things like having an incarcerated household member or having household substance abuse. Here too, you can see some limitations that this by no means represents the entire universe of early adversity. So things like peer victimization or sibling victimization, community violence, other sorts of early adversity that we might imagine might have these same relationships were not in fact assessed in the ACE study. And then the ACE score is really a simplistic score. It's just a sum of the number of categories of ACEs that each participant reported. So for example, if you reported experiencing physical abuse as a child, you would have an ACE score of 1 if that's the only category that you experienced. And if you experienced physical abuse as a child plus you witnessed intimate partner violence, for example, that would be an ACE score of 2. Here I hope you also see some limitations of the ACE score. This does not get into other dimensions of early adversity or the maltreatment experience like severity or chronicity or the age of onset, so other dimensions that we know would be important for outcomes. Despite all of these limitations, more than half of the original Kaiser CDC sample reported having at least one ACE. Again, an insured, mostly higher SES, mostly white sample. Not depicted on this graph, but equally as compelling is that if one category of early adversity or ACE was present, there was an 84% likelihood of additional categories being present. And throughout all of the sort of ACE literature base, you see the same sort of pattern. As your ACE score goes up, so too does your risk for a whole host of health risk behaviors, diseases and injuries, mental health problems, chronic, physical health problems, and they do so in a graded dose-response effect. And I'm about to show you a few graphs to illustrate this pattern of ACE scores and risk for health problems later in life. I should mention that there's been over 40 health outcomes that have been documented using the original Kaiser CDC sample. So again, not only are ACEs common, but they've been repeatedly found to have a graded dose-response effect. Here you can see an example of ACEs and a mental health outcome, adult depression. So on these graphs, on the x-axis, you'll see number of ACEs increasing. And then on the y-axis, you have something called an adjusted odds ratio, which is basically just an indicator comparing two groups on level of risk. So if the odds ratio is 1, the two groups have a similar level of risk. So here you can see as your ACE score increased, your odds of being depressed as an adult also increased. Here you can see that when you had 5 or more ACEs, you're pretty much at a 5-fold increase in risk for being depressed as an adult. Here you can see the same pattern, now not just with mental health, but also with physical health. Same pattern. Again, on some of these particular health outcomes, you may see the most increases in risk at a certain level of early adversity. So here you can see, 7 and 8, you have a threefold risk. But, even if you have 3 ACEs, you're at a 1.5 times risk for having adult cardiovascular disease. So what's important here are not the exact numbers of ACEs that increase your risk, but showing this sort of cumulative increase in risk in this graded dose response pattern. And it's also ACEs and health risk behaviors and sexually transmitted diseases. Here you can see for ever injecting drugs, having 50 or more intercourse partners, and ever having an STD. Again, same graded dose response effect pattern. While the landmark CDC Kaiser ACE studies in adults resulted in this valuable information connecting retrospective surveys of ACEs in childhood with multiple negative outcomes, additional studies, including the National Survey of Children's Exposure to Violence, the longitudinal studies of child abuse and neglect, and the National Survey of Child and Adolescent Well-Being are interested in determining the prevalence of adverse childhood experiences among children and adolescents, so more so in real time. So this is just showing that even studies or surveys that don't use the particular ACE scale have proxy items that really map on to the ACE constructs. And in fact, you can see similar patterns when you look at these data. I should mention that the National Survey of Children's Exposure to Violence is a nationally representative random digit dial survey of normative children and youth in this country. NSCAW-2, the middle column, the National Survey of Child and Adolescent Well-Being, is also nationally representative, but of children that are involved somehow in the child welfare system. And LongScan, the longitudinal studies of child abuse and neglect, is a 5-site study, not nationally representative, but instead a more targeted study around kids who had either substantiated child maltreatment or were deemed high risk for having experienced child maltreatment based on a whole host of risk factors. And here you can just see the increased prevalence when you actually ask ACE-like questions among kids and adolescents themselves. Even in NATSCEV, so again, that was a nationally representative sample of children and adolescents in the U.S., the prevalence is much higher than in the retrospective CDC Kaiser ACE study. Also, almost a quarter of them report 3 or more ACEs. And of course, importantly, you can see the 2 higher risk groups from LongScan and NSCAW having the highest prevalence and reporting the highest level of ACEs, with in orange there being the nationally representative sample of children that are involved in child welfare. So by definition, they probably, just to be included, have multiple of the ACE categories that were assessed. This next slide shows just a deeper dive into those NSCAW data and just illustrates ACEs by ACE group. So again, among this child welfare involved sample. Pretty compelling here. I hope you see that this really depicts the importance of early intervention and identification, and certainly prevention. Because if you see in the white bar, that's the 0 to 2 group. And so kids under the age of 2 years old, 38% already have 4 or more ACEs. And of course, we understand that the number of ACEs increases with time and thereby also increases the accumulation of risk factors. Because of these really important connections, many states, 2 of which you're going to hear from today on this webinar, have started to collect ACE data on their behavioral risk factor surveillance system surveys. Just to point out, the categories of ACEs that are actually captured on the BRFSS are slightly different in that most states do not collect neglect for various reasons. Wisconsin is one of the exceptions to this rule, and you may be hearing more about their work in this area and doing surveillance in neglect as well. And we often get questions, so which states are doing it, or is my state collecting these important data? So here you can see the states that we know of from 2009 to 2013 who have included this optional sort of ACE module on their annual state surveillance efforts. So to date, there's been more than 22 states that have this information. I just want to say that for some, though, it's not just that early adversity has an impact across the life course. It's that for many, adversity continues throughout the life course, and this, in fact, has a compounding and cumulative impact. Which is why, obviously, the role for public health, and certainly CDC's public health approach to violence prevention, is to really emphasize stopping the violence before it occurs in the first place, or primary prevention. By engaging in primary prevention efforts first and foremost, we're thereby stemming the flow of children and families that are going through these other systems, criminal justice, child welfare, and social service systems. Of course, being sensitive to the fact that these experiences are common, they are cross-cutting, they do affect all of us, we obviously need primary, secondary, and tertiary prevention efforts, and we need to respond sensitively once trauma and early adversity have occurred. But in our mission, of course, to achieve change through public health impact and to demonstrate impact, we really sort of rely on this equation, and we focus on changing things that affect many people with frequent exposure and in a comprehensive way, really trying to impact population-level health. And with that goal in mind, we've come up with this vision for all children, and that is our Essentials for Childhood vision, to assure safe, stable, nurturing relationships and environments for all children. In this way, we're in part reframing the issue to go beyond just the absence of violence and trauma in children's lives to more of a focus on what children need to have optimal physical, emotional, and cognitive development. Admittedly, for the past several years, much of this work has focused on healthy relationships between parents and caregivers and children. But we increasingly understand that these relationships are developed within a context that may or may not support children and families. And so we're really expanding the focus to include addressing the social and economic environments in which parents are raising children. So specifically, we are growing our work to include a deliberate focus on health inequities. Because really we think that preventing child maltreatment requires understanding why some children and families are at greater risk than others. So if we know that things such as poverty, parental unemployment, violent neighborhoods are risk factors for child maltreatment, but we also know that these conditions themselves are differentially distributed by race, ethnicity, and socioeconomic position. So we need to start asking ourselves questions like what puts some families and groups consistently at risk for being poor or for being unemployed or for having unstable housing. These are the types of questions we're now exploring in our child maltreatment prevention activities, and many states, including the states that you're going to hear from today, are also tackling these really important questions. I will end by saying the CDC, of course, is also currently funding 5 state public health departments to really implement Essentials for Childhood as a framework for how to address child maltreatment by raising awareness and commitment, using data like the ACE data to inform prevention action, and by creating the context for safe, stable, nurturing relationships and environments through programs, through norms change, and through policies. So I'm going to end there and recognize that we have so much to learn in this area still, and I think the 2 states that are going to be on this webinar today can give us some of their lessons learned and kind of move us ahead in sort of the priority on prevention and the promotion of safe, stable, nurturing relationships and environments for all of our children.
Great. Thank you so much. And we have 5 minutes to address some of the questions that have been chatted in. So thank you for writing in your questions. And we'll just start from the top. And for our presenter, there's also a questions tab at the bottom of your screen where you might be able to look at these questions as I read them for our audience. The first question to you is, have there been any attempts to replicate the study, the ACE study, with more diverse populations and communities?
Yes, that's a great question. There's been several attempts. For one, the BRFSS data at the state level is a more representative sample for residents of that state. So certainly that's why states are really prioritizing collecting these data, particularly for their own states. And I will say, although you'll hear from Wisconsin and Maine who will tell you some of this for their particular states, you see the same relationships between early adversity, or ACEs, and health outcomes even at the state level. There are also populations, like higher risk populations, like the National Crittenden Foundation, who do these sorts of ACE-like studies for their particular population or organization. And again, similar patterns are found. I should also say there's long scan papers and NASCAV, the National Survey of Children's Exposure to Violence papers, that have also looked at, although they didn't have the ACE exact question, but the proxy items, they find the same, this sort of high prevalence and then this relationship with health outcomes, even as early as adolescent health. So I think it's a very robust literature, and we can feel very confident in the relationships between early adversity and health.
Great, thank you. A second question that's in here is are there any efforts being made to rework the study to include other ACEs, for example, sibling abuse or bullying?
So there I would also point again to the National Survey of Children's Exposure to Violence. In particular, the principal investigator of that study is David Finkelhor. And I believe in 2013, it could have been in 2012, he actually put out a paper, I think it's entitled Improving the Adverse Childhood Experiences Scale. And he posits other factors like sibling abuse, property crime, other things that are also forms of early adversity that have the same, if not even more robust in subsettings, relationships with health outcomes.
Great, thank you. There were a couple of questions that I actually am going to read as a pair. One question is, who assigned the ACE construct to the child? And the second, by the same another question from the same participant is, what were the skills of the assessor? For example, the self-assessment by child, assessed by a licensed counselor. So maybe say a little bit more about the ACE constructs for the child and understanding how this assessment works.
Right. So the original Kaiser CDC sample were adults. So there were no child constructs. I think maybe the question is speaking to the three other data sources that I provided there. So NASCAV, the National Survey of Children's Exposure to Violence, they asked these questions in the context of a large victimization study where they have trained interviewers, and you can go on the NASCAV website and find out the specific credentials of those assessors. NSCAW, the National Survey of Child and Adolescent Wellbeing, among the child welfare sample, that was a combination of record review, parent report, child report. So within the context of being involved with child welfare, there were those licensed counselors and child protective service workers that collected those information. And then LongScan, similarly, I actually did my doctoral work on the San Diego site of LongScan and was involved in some assessments. So it's mostly doctoral clinical psychology students or clinical psychologists themselves who assessed a lot of that information. So it varies a little bit by study and by resources. I certainly, if this question is getting to, these are sensitive questions and people need to have a specific sensitivity training or be aware of trauma-informed questionnaires and assessment, I would agree with that.
That's great. And what we'll do is we'll field one more question before we move to our next speaker, but do know that we have a Q&A planned for the end of our program as well, and we will return to our question list at that time. The last question I'll send your way, Melissa, is who should we contact to receive information on what our state is doing on the ACE?
That's a really good question, and we are really working hard now that the study is in the Division of Violence Prevention to try to spearhead some of the coordination of that information. Right now, you can go to the cdc.gov/BRFSS website, and you can search by state. It really varies by state who administers the BRFSS, who's in charge of that data collection. So it does vary by state. But you could always email me, and I can try to find out as well. But the BRFSS website should be your first resource.
Wonderful. Thank you for that information. And again, we will be going back to answer unanswered questions at the end of our program. And as we move to our next presenters, please do also chat in your questions for them. So our next speaker is Karen McEwen. Karen has served as the administrator of the Wisconsin Division of Public Health since January 2012. Previously, she worked as an oncology staff nurse and leader for 11 years, overseeing the clinical operations of inpatient and outpatient oncology departments. Karen's health policy experience includes a student fellowship with the U.S. Senate Finance Committee and a graduate fellowship with the Heritage Foundation. She's also worked with the Oncology Nursing Society on policy-related projects. And Wisconsin is very involved with work on ACEs, so I am very excited to turn it over to our next presenter, Karen McEwen.
Good morning. I'm delighted to join you this morning and to have this opportunity to speak with all of you. We in Wisconsin have included the ACE module in the BRFSS since 2010, and our findings have been very similar to national findings. We have found that ACEs are common, ACEs are interrelated, and ACEs are associated with mental health outcomes, health risk behaviors, physical health outcomes, socioeconomic status, Medicaid and Badger Care enrollment, and quality of life. We really value the data that we get on this, and so we plan to continue to include this in our BRFSS survey. And we have multiple agencies and partners included in that, and annually we put out a call to multiple partners to ensure that we have funds to purchase that module. As I go through this presentation, I'll be pointing out that our ACE findings have implications for both prevention and interventions. So I said that ACEs are common. In Wisconsin, we have found that 58% of Wisconsin adults report growing up experiencing at least one ACE, and of those, 25% reported having 4 or more ACEs. We've also been able to map this by county. This map of Wisconsin shows the percentage of Wisconsin residents by county who reported 4 or more ACEs. So the red shade, that darker color, 13 of our 72 counties, indicates that more than 20% of those counties' adult residents have 4 or more ACEs. And do note that older people seem to report fewer ACEs, possibly for cultural reasons, and because the median age varies quite a bit by county, that may also be reflected, and some counties may not be showing as many ACEs because the population is older. I also said that we have found that ACEs are interrelated. Our results show that certain adverse childhood experiences were highly correlated with an ACE score of 4 or more. In this graph, for example, of those individuals who reported that they grew up with a household member who was incarcerated, 63% reported having experienced at least 4 ACEs. And there are similar results for those who reported growing up witnessing violence in the home. We see disparities in our ACE results. In the 2011-2012 brief, we focused on ACEs and socioeconomic status and race. Wisconsin is one of the first states to explore more deeply the association of ACEs and health outcomes as they vary by race and income. On this slide, you can see that ACEs correlate with education level. Typically, we say that correlation does not imply causation, and that's certainly true here, except to the extent that we know ACEs occur in childhood and education occurs later on. So if people are dropping out of high school, it's quite likely that the ACEs came first. So prevention could possibly improve educational outcomes. So because we know, I don't have to remind you how many studies have found an association between health outcomes and education, so this is really significant for public health. As you see on this slide, those with an ACE score of 4 or more were significantly less likely to complete high school. 28% of those who did not complete high school have an ACE score of 4 or more, compared to only 10% of those who were college graduates. ACE scores also correlate with income. Respondents with a yearly income of $25,000 or less are 27% less likely to report 0 ACEs and almost twice as likely to report 4 or more ACEs. Again, these are adverse childhood experiences, so ACE comes first in this correlation. When we look at specific ACEs and income, the largest difference between the types of ACE and income are for divorce and separation and incarceration of a household member. For example, lower income adults are 3 times more likely to report an incarcerated household member during childhood. Wisconsin has added questions on poverty in our 2014 BRFSS, and will have additional analysis on the association of ACEs and income in 2015. There are also noticeable differences in ACE scores and types of health insurance. Individuals on Badger Care, or Medicaid, or without any insurance are more than twice as likely to have experienced 4 or more ACEs. Here again, there are implications for prevention and intervention. If we can prevent ACEs, we can increase educational attainment and income, and probably have fewer people on Medicaid and uninsured. And for interventions, we are including trauma-informed care concepts in our Medicaid program. When we look at ACEs and race, in Wisconsin we found that Black respondents have higher ACE scores than other races and are least likely to report 0 ACEs and more than twice as likely to report 4 or more. Looking at specific ACEs and race, this graph shows the types of ACEs experienced by race. 58% of Black respondents reported parental divorce or separation, compared to 22% of whites. Additionally, Black respondents were 4 times more likely than whites to report growing up with an incarcerated household member. Looking at some of the specific implications then for prevention, we know that if we can prevent ACEs, we can make a significant impact on improving public health, reducing risky behaviors, and decreasing costs for deep-end systems. Prevention can be advanced through public awareness, as well as formal prevention services for families facing challenges. We know that knowledge about the co-occurrence of ACEs can help mitigate exposure to additional adverse childhood experiences and improve the effectiveness of prevention services. So if we have identified a child who's experiencing one ACE, we can try to make sure that they don't pile more ACEs on top. Additionally, specific interventions targeted at parents who have ACEs themselves can help prevent the transmission of ACEs to their children and stop the intergenerational cycle of adverse childhood experiences. So, for example, we are beginning to provide training on ACEs to our prenatal care coordinators. Looking at the implications for intervention, identifying and promoting protective factors among adults and children can help build resilience and lessen the impact of adverse childhood experiences. Children experiencing toxic stress and adults who still suffer the effects of ACEs need appropriate support to process those experiences. Given the co-occurrence of ACEs, intervention for one ACE should always include assessment for other ACEs and appropriate interventions. And social services and health systems should continue to move towards building more trauma-informed care practices and interventions. Looking ahead in Wisconsin, we are utilizing our ACE data to inform policies, practices, and prevention efforts statewide. Specifically, the ACE and Trauma Work Group convened by the Children's Trust Fund has prioritized the following areas of work. 1, increasing public awareness of adverse childhood experiences, including working closely with our First Lady and her Fostering Futures initiative to broadly disseminate ACE findings. 2, partnering with the Department of Corrections to identify strategies that will improve outcomes for children growing up with an incarcerated parent or household member. You'll remember that that's one of the ACEs that is most correlated with having 4 or more ACEs. Here at the Department of Health Services, partnering with Medicaid to incorporate what we know about ACEs into Badger Care and Medicaid policies and services. And 4, enhancing ACE data to better inform policies and prevention efforts in Wisconsin. In 2013, we oversampled the Native American population and translated the entire BRFSS into Spanish. We will be receiving those weighted data from CDC very soon. And then in 2014, we added questions on poverty and child neglect. We will also continue to do deeper analysis on the association of ACEs to health outcomes as they vary by race and income. In Wisconsin, we're also working to increase the saturation of knowledge about ACEs within our agencies. Here at the Department of Health Services, our Deputy Administrator is on the Children's Trust Fund and has become a strong supporter of ACE throughout the department. And trauma-informed care is also, we're also highly promoting that. That originated here at the Department of Health Services, and we're making sure that it goes out to the mental health community, in Medicaid, and in other programs. At the Department of Public Instruction, there's a strong initiative on trauma-informed care throughout the state, including ACEs as a contributing factor to behavior and academic success. And the Department of Children and Families, they are incorporating trauma-informed care and ACEs into child services agencies at the county level with intense training and evaluation of practice, and they're also including that in their home visitation program. In 2013, our legislature released a joint statement, the Senate Joint 59, relating to early childhood brain development, a joint resolution, in which, resolved by the Senate with the Assembly concurring, they decided that policy decisions enacted by the Wisconsin State Legislature will acknowledge and take into account the principles of early childhood brain development and will, whenever possible, consider the concepts of toxic stress, early adversity, and buffering relationships, and note the role of early intervention and investment in early childhood years as important strategies to achieve a lasting foundation for a more prosperous and sustainable state through investing in human capital. In public health, one of the places we've really focused on ACEs has been in our HIV/AIDS work, where ACEs have implication, again, for both prevention and intervention. In the original Kaiser study, the prevalence of injection drug use rose from 0.3% for those with no ACEs to 3.4% for those with 4 ACEs. We know that exposure to trauma, both in childhood and adulthood, can put individuals at greater risk for acquiring HIV. And national and local studies have documented links between ACEs and negative adult health outcomes, including increased likelihood of engaging in risk behaviors that may lead to HIV infection. There's a powerful association between ACE scores and risk behaviors, including drug use and sexual activity. In a recent study, Chicago men who have sex with men who had 4 or more ACEs were twice as likely to have unprotected sex with a casual partner and were twice as likely to report being afraid to find out their current HIV status. This has implications for HIV prevention work. Recent studies report that people living with HIV have experienced higher levels of childhood trauma than the general population, and also that among people with HIV, a trauma history has been associated with higher all-cause death rates, more likely progression to AIDS, impairment in daily functioning, antiretroviral failure, lower condom usage, and development of opportunistic infections. Recognizing these links, in 2013, our HIV/AIDS program required all contractees to view webinars on ACEs and HIV and on trauma-informed care. The statewide Action Planning Committee reviewed and approved a focus paper on ACEs and HIV in Wisconsin for addition to the Wisconsin HIV/AIDS strategy. And we are planning additional training for prevention providers and case managers. The HIV/AIDS program will develop formal mechanisms to collect client feedback on funded HIV services ranging from prevention to care and treatment to monitor for trauma-informed care practices. And the HIV/AIDS program will continue to increase awareness of trauma, ACEs, and their impact on people at risk for and living with HIV. I'm happy to take questions, and I'm joined in the room here by Jennifer Jones, the Interim Executive Director of the Wisconsin Children's Trust Fund, who has done so much work on ACEs, and by Susan LaFlash, our Violence Prevention Program Coordinator.
Thank you so much for that presentation, and we do have a few moments for questions. I know a number of you are chatting in your questions, and I'm going to pull out the ones that are specified for you guys in Wisconsin first. One question for you is, beyond equipping professionals and frontline workers, for example, you mentioned the DHS, how does Wisconsin engage non-traditional partners, nonprofits, faith communities, to engage in both prevention and intervention?
I can definitely speak first of all to the HIV/AIDS community, where we have worked with some of the some of the community partners in Milwaukee that don't just focus on health, and we've worked with them to raise awareness of ACEs and the impact that those can have. And this is Jennifer.
This is Jennifer from the Children's Trust Fund. The other areas, I think, include, we have a wide variety of members on our ACE and Trauma Work Group, both nonprofit, private agencies. We also most recently have engaged with our Wisconsin Economic Development Corporation to focus intensely on efforts to engage the business sector. So we are definitely involved in coordinating efforts among all key stakeholders and folks engaged with children and families throughout the state.
And because of the high level of interest across the state agencies, there have been conversations at the cabinet level, and that's, for example, how Department of Corrections became so engaged. They heard this and said, wow, this is the kids of our population.
Great, thank you. There are a couple more questions specifically indicated for Wisconsin. One question is, where are the funds coming from, and how much is Wisconsin investing in ACEs?
This is Jennifer. Since 2009, the Children's Trust Fund has led or convened a small group of individuals, and we have raised the money to include the ACE module into the Behavioral Risk Factor Survey. It costs us about anywhere from $28,000 to $35,000 a year just to include the ACE module and the BRFIS. We also spent, the Children's Trust Fund invested funds in oversampling the Native American population and translating the BRFIS into Spanish, and also developing the questions to include in our 2014 BRFIS on poverty and child neglect. So a significant amount of the funding has come from the Children's Trust Fund, and then our partner agencies at the Department of Health Services, at the Department of Children and Families, and certainly at the Department of Corrections. We also work in close partnership with the Child Abuse Prevention Fund at Children's Hospital. They have been a key partner in this work and have helped us issue all of the publications that have come out of our data findings.
And this is Sue. In the Department of Health Services, it's primarily come from the Mental Health and Substance Abuse Division, trauma-informed care area. And this is just an unusual source, which is why I pointed out, is that I oversee the rape prevention and education funds out of CDC, and I utilize their surveillance funds to help support the module purchase. So there's definitely ways and options to get the money together if you think broadly about the implications of ACEs.
Great, thank you. I think we have a moment to squeeze in a couple of additional questions before moving on to our next presenter. And again, any unanswered questions, we will attempt to get to as many of them as possible in our Q&A at the end. Another question for Wisconsin is whether you can go into a little more detail about how the Department of Children and Families is using ACEs in home visiting.
This is Jennifer. I will just say a couple of things. One is the Department of Children and Families has created a Wisconsin Trauma Project, and they are working with several pilot communities, in particular the Child Protective Services systems, in using the education around ACEs to build more trauma-informed care systems. The home visiting program is just gearing up to start working specifically on how we train and educate home visitors to understand the implications of adverse childhood experiences and use that specifically in their practice. I know that isn't in detail, but we can certainly provide more information from our home visiting folks.
Great, thank you. And one last question before we move on, since a couple of people have chatted in where they can find a copy of Wisconsin's Senate Joint Resolution.
We'd be happy to provide that to you if you'd be able to share it in some way. Or, I mean, I think you could probably Google it. I just saw a news flash yesterday that California did a similar resolution using ours as a model.
That's great. We have breaking news right on today's webinar, and any materials that we can gather and share with participants after the program today. So we're happy to try to collect some of that information and be the conduit to share anything with our participants. We've had some resources chatted in as well. So we will be bundling that to share with everyone following the webinar. And with that, I would like to move on to our next presenter. And again, we're going to return to that Q&A at the end of all of our presentations today. So thank you. We're now going to move to our next speaker in Maine. So we have with us Dr. Sheila Panett. She is the director of the Maine Center for Disease Control and Prevention. Dr. Panett has a diverse medical background. Previously, she developed the outreach program for the state of Maine and the maternal fetal medicine division at Maine Medical Center. She cared for high-risk moms in the program for 7 years. She was dual boarded by both the allopathic and osteopathic boards of medicine. And I also want to say that she chairs our ASTHO Prevention Policy Committee, and that this committee named ACEs among its priority interest areas for this year. And so we're thrilled that she can join us, and I'm happy to turn it over to you, Dr. Panett.
Ladies and gentlemen. Sorry, Ms. Chaikin, just want to let you know Dr. Panett's line has disconnected. I will rejoin her momentarily.
Okay. Well, what we can do in the meantime while we have Dr. Panett reconnect is to maybe go to another couple of, maybe another chat question while she does reconnect this morning. One other question, if so, this is back to you, Wisconsin, for while we wait. Can you address to what extent is ACE data being utilized in state or local substance abuse prevention efforts in your state?
This is Sue. We are introducing it through our mental health and substance abuse work comes out of the same division, so it is becoming infused in their work.
Thanks for the very generous opening and introduction. And I'm sorry, just as you were doing that, I was just sitting here and the phone got cut off, so sorry about that.
No worries, Dr. Panett. So why don't we, I know that I think we will go to you and let us return to the question about Wisconsin after Dr. Panett presents. So if we can put a bookmark in that part, and thanks to everyone for your patience and with our is reconnecting Dr. Panett. Go ahead, Dr. Panett, and we will advance your slides for you if you just indicate next. Thank you.
Okay, thank you. Thank you, Len. So Maine demographics and risk factors. Let me first tell you all a little bit about our beautiful state of Maine, where it's known as vacation land, and it is a very rural state with a population of about 1.3 million people. Most of the density of the population occurs along the coastal waterways and along I-95 corridor. We have most of our economic base is south of Bangor. And north of Bangor, we have a lot of industry, which is pretty much potato farmers, broccoli farmers, blueberry farmers, and lumber, so paper mills. So kind of have a high incidence of poverty in that area. We also have 5 regions with 4 nationally recognized Native American tribes, the Micmacs, the Maliseets, the Passamaquoddy, and the Penobscot, which equals about 10,000 of our population. We have 16 counties, and we have spread ACEs education throughout all 16 of those counties. We have a poverty rate of approximately 11.2%, which is very close neck and neck with that of Massachusetts for poverty. In 2010, records show us that 23.5% of children under the age of 5 in our state lived in poverty. And nationally, that number is 1 in 5 as well. In Maine, we say 1 in 4 children live in poverty and have at least 2 or more ACEs. 3 out of our 16 counties, mostly in the north, 1 in 3 children live in poverty. Under the age of 5, 57.4% of the children in the state of Maine are on our Maine Care System or Medicaid. And we know that 17% of all children in our public schools throughout our state in the year 2011 were reported to be receiving special education services. In 2011, Native Americans were noted to only have 4% of them graduate from high school. We have a lot of isolation in the north. There's only one major highway, so there's lack of access to health care, lack of transportation. Even the internet has just started going to the far north to the Canadian border, but people have problems with access, and so we have a lot of donors right now just trying to help us get that last mile and help internet services go out, but broadband does go to the Canadian border. So with that said, many of our people are isolated and have conditions such that they have very few resources to live by. And as you all know, education is empowering. It's a key opportunity. And we have one of the highest unemployment rates in our state. We lack a very strong economic base in the north. 80% of our children who do not graduate high school do not have jobs, and those who do graduate, only 47% of them are not part of the workforce that do not go on to college. We had our Maine Youth Integrated Services, which is a integrated survey done in the school starting in 2009 every other year, looking at substance abuse, tobacco use, alcoholism, drug abuse, mental health issues, and just behaviors such as whether they are eating healthy foods and exercising. And one of the questions asked I thought was very telling. Do you believe that people care about you? And in 2011, 48% of children said yes. But in 2013, that number has decreased to 43%, which is quite unfortunate because we know that role models and mentors are adults. And we need to show our children that we care about them and that we are here to help them achieve their hopes and dreams. In data for children under 0 to 17 years old, we know that there's victims of substantiated maltreatment. In 2009, figures show that 13.4 out of every 1,000 children in our state had some type of abuse. In 2009, 9.6 out of every 1,000 children in our state were considered to be victims of neglect. And we know in 2013, children who are in homes with IV drug abuse have parents that have had 4 ACEs or more, and that number has quadrupled over the last 4 years. In those MAIA surveys in 2009, 2011, 2013, we have questions about bullying in the middle school, bullying in high school, and bullying, depression, and suicidal thoughts. And that rate is considered to be in a range between 13 and 15% and has remained steady over the last 5 years. Next slide, please. So ACEs are experiences in childhood that make you unhappy and unpleasant and are bothersome and hurtful. Maine's been doing a lot of work on this. They've been working on this since 1996, beginning with federal grants for our Native American Passamaquoddy tribe, which had suffered lots of trauma. In 2010, 2011, they conducted an ACE survey demonstrating that people wanted to know more, but actually did not know very much about all the work that's been going on in the world of adverse childhood experiences. So in 2012, after that survey had come out, a group of interested providers, healthcare workers, and philanthropy foundations came together to develop the Maine Resilience Building Network, which was established in 2012. It originally began with 8 individuals and now has 132 people who are interested in trying to help individuals and join in the conversation to educate and support our youth. Our mission is to start the conversation and foster action, to foster resilience through positive change, to develop relationships, to foster education, because lower education definitely has a strong correlation with increased ACEs, to foster awareness throughout our state and help people understand what adverse childhood events are all about and how just through simple conversation and helping people to feel of value that our children can have better outcomes. We want to try to start fostering action and impact our public policy, working with families and children, and enter into conversations with key policy makers. We're not as far along as other people, such as Wisconsin and California, so we are still working towards those crucial conversations to have the positive reinforcement and to support our young children so that we can impact public safety, chronic disease, and help to improve our socioeconomic base. Next slide. So here's the Maine Resilience Building Network logic model that has just been developed over the last year and a half. And so on the left, you see what we have for resources and the partners that we need to call upon. Right now, we work very closely with the Office of Child and Family Services and Public Safety and the corrections people, but we need to touch a lot more lives. And so with the collaboration of those people who are part of the Maine Resilient Building Network known as MERBN, we are trying to establish common communications and reinforce the activities that are successful. And we're finding that to achieve this, we really got to have those crucial community conversations on multiple levels in our areas of employment and our schools, and we need to start early. So this is kind of like a roadmap of the work that we need to do, and in an effort to achieve our goals of increasing awareness and teaching about prevention of ACEs so that we can have a better tomorrow. So next slide. So the focus is really in our state right now is we believe that you need to start young and you need to start prenatally talking to moms and helping to educate them about the importance of identifying what their ACEs are in the first place and if it's bothering them and how we can help them work through that. People can have ACEs and still be successful as long as they're supported and mentored and have positive, caring people that demonstrate that they can have self-worth and they can have value. Next slide. So earlier, Melissa talked on this about the key points about ACEs, and we take that under very strong consideration, and we recognize that it's not how often, it's not the volume or the intensity of the ACE. All you need is to have that one-time occurrence regardless of the intensity. And we know that if you have 4 or more ACEs in our state, those are the people who are having the most trouble. And we know that our IV drug use population and the children born to these patients who are addicted has quadrupled over the last 3 years. We have 990 children this past year in 2013 of our population of 13,000 births that actually were born drug addicted, filling our neonatal intensive cares. And of those, 400 actually went to foster homes. This is sad, and we really believe in the family unit and want to keep these families together. So we feel that this is a very important part to begin focusing prenatally on moms and families. We know that women in our state, over 50% of them who have had 5 or more ACEs, oftentimes are sexually abused, victims of domestic violence, substance abuse, or drug abuse. So our goal is to try to ask those crucial questions. What are your ACEs? Don't be ashamed of them. And how do they bother you? And if they bother you, how can we help? Next slide. As you all know, ACEs can last a lifetime, but they don't have to. They're multi-generational, and they are in a vicious cycle. So we learn a lot of what we experience in our lives through our parents. And the most important thing that we want to focus on is a more holistic approach in terms of healing and educating people and training new parents how to be in a safe place, how to have a stable home environment, and to nurture the relationships both between the mother, the child, the father, and siblings. Because relationships in the end are crucial. They are all about promoting resilience and reducing the negative impact that ACEs bring about. Next slide. So what makes a difference? Well, not everyone with an ACE experiences negative outcomes. So that's why we always ask that question, are you bothered or are you not bothered? And that's where resilience comes in. And the major focus for us is all about communication and constructing an avenue of conversation to promote resilience in our lives. Next slide. So resilience is the ability to overcome stresses and adversity from our childhood. It's built through the support of relationships, positive life experiences, and learning skills to cope and to overcome the challenges that we find with ACEs. Early recognition, as early as infancy and early childhood, can help us revive and decrease toxic stress. Next slide. So the main resiliency building network has defined resiliency as the ability to work with adversity in such a way that one comes through it unharmed or even better for the experience. Resilience means facing life's difficulties with courage and patience, refusing to give up. We actually have a program in the northern part of our state that says, bring it on. In other words, tell us your story and we're going to help you get through it. It's the quality of character that allows a person or a group of people to rebound from misfortune, hardships, and traumas. Resilience is rooted in a tenacity of our spirit, a determination to embrace all that makes life worth living, even in the face of overwhelming odds. Much of our resilience comes from our community, from relationships that allow us to lean on each other for support when we need it. Next slide, please. So these are some of the guiding principles that we have put into action as we've tried to deal with trauma and inform patients about the key of resilience. And we've listed a lot of words here for you to look at that have been adapted from the child and family professionals and Arabella Perez, who's the executive director of that. The key point here is that relationships matter. Each one of us knows that someone who has faced incredible challenges yet beat the odds. Yet others in some situations are unable to overcome those challenges. And as you know, the work that was done by Dr. Felitti and Dr. Ida on the original work, that was in middle to upper class people. And we know that people that live in that vicious cycle of poverty have much higher ACEs and many more difficult challenges to overcome. So what makes the difference? We in the state of Maine believe that it's developing strong relationships. As individuals who are interacting with other individuals, we need to listen. We need to show compassion. We need to understand, and we need to care. We need to carry out respectful and non-judgmental conversations. Most importantly, we need to demonstrate affirmation and validation that we understand that they feel pain. Yeah, you've had a lousy day, and you've had a lot of lousy things that have happened to you in your life. But how do your ACEs bother you? And then from there, we have to go and try to figure out how to highlight their strengths and how to focus on the positives that they have in life. Are they a good musician? Are they an artist? Are they good with math? Are they a poet? We need to help them guide and move forward, and don't look for blame or to bring about shame. Because the most important thing is to help each and every person feel valued in this life. Next slide, please. So some of the questions we ask, especially as we work with our opioid-addicted pregnant women, is what are the ways in which you're parented that you intend to practice with your new baby? And one of the things that we've found through our own experiences is that you can teach people all you want about child development and how to raise your baby, but the most important teacher is your own parents and your own life experiences and in the home that you were raised. And you tend to bring those values and those teachings with you. And so how do you want to change things? What are some of the things in your childhood that you experienced that you don't want to have happen to your baby? What do you want to do different? Or you could use ACE non-categorical screening and focus and promote on resilience that helps to reduce the impact of ACEs that you already have. And how are ACEs affecting your pregnancy? Are you stressed? Do you feel anxious? Do you feel depressed? And help guide them through those difficult times and those conversations. Find them resources. Connect. Not everybody needs to be connected to a mental health worker. It's our feeling that sometimes it's just a listening ear or somebody who's being patient. Families with young children, we use the non-categorical ACE screen to focus and promote on resiliency that helps to reduce the impact of ACEs already. So how do the ACEs still bother you after your relationship with your child? So with that said, we're working with our medical professionals, pediatricians, obstetricians, nurses, family practitioners, and we're trying to educate them on how to learn about what ACEs are all about and how to increase positive impact on the overall health of our pregnant moms so that we can have healthy moms and healthy babies. And we feel that our providers are an integral part of this process because our teachings are and experiences are that one of the strongest relationships you have are with your healthcare provider, where you feel that you can trust and tell the truth. Not all patients need to have that mental health consult. And right now we have an experience going on in public health nurses in Bangor, Maine, where we're rolling out a home visiting and public health nurse acuity, trying to decide who really needs to see a public health nurse. Maybe they just need to see a home visitor, somebody who can come in and talk to them. We certainly have an algorithm by which we screen people so that we know whether they have the babies at risk for medical problems. But if it's just having somebody to talk to, someone to make them feel like they're of value, somebody who can help them get resources or guide them how to get their GED or how to dress their baby or bathe their baby, then we can have home visitors go in and help with that. Certainly our home visitors are trained. Next slide. So essential protective factors are conditions that increase health and well-being for the children and buffers that provide support and coping strategies to parents. And here's the website of some of that information. We want to develop and continue to have resiliency in our parents. We want them to feel a part of the community. As you all know, being part of a community makes you feel good. And we need to help them develop social networks and relationships because then they'll be successful. So know about the child development and parenting. We already talked about that. That was an old traditional way, and we have found in Maine that it's not as effective. Most parents learn from their own parents and their own childhood experiences, and that's going to be variable, so very individualized. Are you feeling supported in your times of need? Are your basic Maslow's hierarchy being met? Food, clothing, shelter, and water. How can we assist you with those things? Sometimes you'll be surprised to find that people are living in camps or living in cars, and so especially in our more rural areas. People with ACEs need to learn to nurture and to respond to their children's needs, and they need to be taught those things. And so we have developed classes of skill building to help teach, especially our new moms and new parents, how to develop a circle of security. So next slide. So we like this slide. It's actually from Cooper, Hoffman, Marvin, and Powell, and it's called the Circle of Security, and it's a natural curriculum that's being used nationally, and it's simple and easy to understand. In Maine, we're using a lot of our prenatal classes, a simplistic way to help people understand that the child says, I need you. I need you to support my exploration. I need you to watch over me and help me. Enjoy with me. Delight in me. I need you to welcome me and welcome me with open arms. I need you to protect me, to comfort me, to delight in me, and to help me organize my feelings. I need you because you are my security, my base, my safe haven. So the connection that we all feel is emotional because this affects providers, this affects parents, and this is how we develop healthy, happy children. Next slide, please. So it's all about building resilience, and we know that the essential characteristics are to be calm when you're talking, to be deliberate, purposeful, supportive, and caring, to not be judgmental, to be compassionate, to be genuine, and to create a physical and emotional safety net, to help people learn how to cope with their feelings and deal with behaviors. And most importantly, those of us who are entering into these crucial conversations, we have to be patient. Sometimes people aren't readily going to be telling you their deep, dark secrets, mainly because they're afraid, and they need to make sure they can trust you. And it may require sometimes that you have to give up your own agenda when you're talking to these people. You need to listen and understand and do it on their timeline because trust is so important. Next slide. So here's our website. This is the Maine Resilience Building Network, and you can go to it at maineaces.org and find out more information on what we're doing here in Maine. It's a little more holistic. Next slide, Prevent ACEs in Maine. And these are all the groups and partners that we are engaging with to inform, educate families in the public system so that we can touch more lives. And as you know, no one can do this alone. We're all in this together. It's a partnership. So we look forward to informing and engaging with more Mainers. We're cognizant of the fact that there are many discrete and collective groups that we can collaborate with, and we're reaching out to them now. We know that to make the biggest impact, we need to be in a partnership at all levels, state, county, and local levels across all organizational bodies and sectors. And most importantly, understanding and preventing ACEs is a universal priority. We can get things done if we do it one community at a time, and we are looking forward to working with key stakeholders to achieve these monumental goals. Next slide. Looks like I went off. Mine went off, but we have 9 major initiatives or tools that are being used to help local trainers work statewide with people to recognize that there are different ways, and every process is individual. We are championing with the Bingham program, which is a philanthropy group that we have been getting donations from since 2012, and they will be giving us another $98,000 this year so that we can train more people to go out with this method and help us hopefully collect data, which is very important. Maine Developmental Foundation is our fiscal agent, and it's bringing our business communities in so that we can help understand how ACEs affect our workforce and poverty in Maine. Together, through our partners, we are in all 16 counties. We've trained 3,400 adults to go out and reach out in the communities to help our children. We're looking to spread the message, educate, and stimulate involvement, and to engage people in the conversation. And that's our tagline, join in the conversation. Next slide. So we have a society that we want to prosper in the future, especially in our state. We need to make sure that all our children have the opportunity to develop intellectually, socially, and emotionally. And our last slide is Sue Mackey-Andrews is actually one of the co-founders of the ACE work in our state. She's dedicated her life to children and families in hopes of bringing about a brighter and happier tomorrow, and she's a major resource. As you can see, her name's on the slide. She is the chair of the Maine Resilience Building Network as well, and certainly you can always contact me if you have any questions. Thank you very much.
Fantastic. Thank you so much. And what we'll do is there are a couple of specific questions for you, and then we will move to the many questions that many of you have written in. And so thank you for all of your questions, and we will get to as many as we can in the course of the remainder of this webinar. One question that came in, and this was when you were going through some of your demographics and risk factor data earlier in your presentation. Someone was interested to know where the data was from when you were referring to 48% of children saying that they believed there were people who cared about them, and then you noted that there was a decrease in that percentage. What is the data source for
that's through the survey. It's an integrated survey that I talked about, the MIAS survey, Maine Youth Integrated Survey, that is done and offered to all the schools. It's done one time a year, every other year. And so it was done in 2009, 2011, 2013, and it combined 3 surveys. We used to have one just for substance abuse. We used to have one just on healthy habits, and we used to have one on mental health issues. And now we have put them all together, and that is one of the questions. Do I believe people care about me? And so that was one of the questions that was kind of bothersome, because we had a down slide from 2011 from 48% to 43%. And those are from schools. They're actually from kids in middle school and high school.
Thank you. Another question was, how does the Maine Resilience Building Network raise the community's interest enough to attract high ACEs individuals to participate in resiliency programs?
Well, actually, we have coalitions throughout the state known as Healthy Maine Partnerships that work on the levels as well at the community level. They're boots on the ground, and they're all focusing on adverse childhood experiences as one of their issues that they want to address. We also have the Maine Children's Growth Council, which was established by our governor in 2007 to help fund early childhood comprehensive system where we can develop and evaluate sustainable social and financial programs to help evaluate youth and their families in our state. We also have district coordinating councils, which are councils that are set up with all different stakeholders, business stakeholders, anything, hospitals that will impact the health of the district. And our districts are divided up into a total of 8 with 1 tribal district, and those districts are looking over 2 to 3 counties in most instances.
Great, thank you. And one last Maine-specific question before we start to get to some of the broader questions, even questions that are going to both Maine and Wisconsin, so we'll open it up. But one last question for you, Dr. Panett. What did you mean by the ACE non-categorical screen that you mentioned earlier in your presentation?
They did not have a category. They were other factors that are not part of the screening, actually, of the ACE screen that people wrote down and said that they had issues with.
Thank you so much. And I'm going to now go back to our bookmark in our program, the question that came in that is now actually for both Wisconsin and Maine. So this is a question for all the folks sitting in both of those states. To what extent is your state or local community using data on child adversity in broader substance abuse prevention efforts? So this is for Karen McEwen, this is for Sheila Panett, and anyone can kind of jump in.
So this is Karen. In Wisconsin, substance abuse efforts have historically been led by the Division of Mental Health and Substance Abuse Services, and public health hasn't necessarily had a big role in that. That is definitely changing, partly with the ASTHO President's Challenge this year and just so much awareness there. It's a big problem in Wisconsin. The local health departments are working on substance abuse, and at the state level, our division is beginning to look at what is our role and how can we work on the prevention side, and ACEs will definitely be part of that. But with the mental health and the treatment side, they're incorporating ACEs and trauma-informed care into their work.
This is Dr. Panett. In the state of Maine, the public safety and substance abuse and mental health services as well have been taking on with law enforcement all aspects of looking at substance abuse. It's a major problem in our state. We as public health, it is not under our jurisdiction. However, we make it part of our jurisdiction, and we kind of are cross-collaborating throughout the department to at least put out messaging and about the importance of value, self-worth, and the importance that being drug-free has on helping to keep your family well together.
Great, thank you. And I think what we'll move to now are some of the broader questions as we have about 4 minutes left in our program. And again, to the extent we can help provide resources and information for unanswered questions, we will, and with the materials we share with participants after today's program. And so with that being said, I'm just going to try to scroll through and look at some of the broader questions for the panel. And we have a very engaged audience, and we have a pretty interesting range of questions. One broader question to the group is whether there is an ACE and or Essentials for Childhood national social media campaign that can be shared for increased reach and consistency. So this goes to any of our panelists.
So this is Melissa Merrick from CDC. So right now there's not a national social media campaign, but we are engaging social media throughout the year. In Child Abuse Prevention Month, we had a very robust Facebook chat, or I'm not sure what they call them, Facebook or Twitter town hall. I think also there's a lot of norms work going on. And if I may, I wanted to end with sort of a final point here in terms of, early adversity is not deterministic. So not all maltreated kids or all kids that experience early adversity go on to have poor health outcomes. And so we know that there are these factors that can buffer or protect against poor health outcomes, and that is where this vision for all children and families comes up. I mentioned that CDC is supporting 5 states to implement Essentials for Childhood with a particular focus on the context that support safe, stable, nurturing relationships and environments. And those are really critically important in supporting and building resilience and to make those who have experienced early adversity still able to reach their maximum health and life potential. I should also mention, though, there are an additional 20 states, Wisconsin among the pioneers in that are implementing essentials, just not with CDC funds. So with these traditional and non-traditional partners, through a very robust social norms campaign, through trying to change policies in their states, trying to engage business sectors and various sectors. So it's not just about the sort of individual relationship level of the social ecology. We need to move out to community organizations and interventions that I think Maine covered very well, but we also need to be broader than that even into social norms, into policies, into the contexts that are really going to support children and family over the life course. So with that, I think we will have a social media campaign. I think it's a great idea. We don't currently have one per se.
And there was another question, Dr. Merrick, that relates to this idea. Someone was asking, are there models where public health and other social service professionals can advocate for social change that address environmental factors that you're referring to? And so maybe as our last point for this Q&A, if you would want to expand on that, since we really have talked a lot today about how to apply ACEs and essentials for primary prevention.
I'm sorry, can you repeat the question? I was getting some feedback.
I'm sorry. So the question was whether there are models where public health and social service professionals can advocate for social change that addresses the environmental factors you were just referring to. Maybe this will be our last question for our program before we close.
Yeah, I think that's a great question. And we are currently, I should mention, we have an interagency agreement with the Office of Child Abuse and Neglect through the Administration for Children and Families to support the ACE work. And through that partnership with OCAN, we are developing resources and tools for both the CBCAP, the Community-Based Child Abuse Prevention grantees, as well as for public health practitioners and for policymakers, where we're going to have a series of resources. One example, I think, that gets to this question really well is a series of state case studies. And actually, Washington State and Wisconsin are the first two states that will be part of this case study series. And this will really help learn from other states that may be at different waves of the process in terms of engaging non-traditional partners, media, policy folks, and really on these other structural determinants of health like poverty and race, ethnicity, et cetera. So that is coming. We're also developing an ACE infographic of sorts, some tool that will live online about making the prevention case for ACEs, so not just about the data. And this really sticks to our 4 goal areas of essentials in terms of raising awareness and commitment, using data to inform action, and then creating the context through norms and policy change. So on the Essentials website, there are actual resources in addition to the technical package which describes the 4 goal areas. There's some additional resources that you can go online right now in terms of building commitment, in terms of positive community norms, and specific strategies on working with media. Coming. The last one is coming. Working with media is coming. But the other 2, and there's other resources throughout our web pages that we really encourage folks to seek out.
Thank you so much. And with that, I would like to thank our speakers, Melissa Merrick, Karen McEwen, Sheila Panett, for all that you've shared with our very engaged audience today. Thank you to all of you for participating, and for those who have participated, please fill out the evaluation that comes up at the conclusion of the webinar. It will help us design future presentations. We also want to thank the support from the National Center on Injury Prevention and Control for sponsoring this webinar. This is the second of 5. We will make sure that you get information about upcoming webinars as well as resources and information resulting from today's program. So with that, we hope that you will use this as a resource. You can share the information with others. We know that this is a big area of interest. And so with that, I will conclude today's program. Thank you to everyone for participating.
Ladies and gentlemen, that does conclude the webinar for today. We thank you for your participation and ask that you please disconnect your line.